Welcome to this explainer on the newly consolidated CPT code family for home and residence evaluation and management services. We're talking specifically about codes 99341 through 99350 today. You know, if you've been in the medical coding world for a while, you completely understand that trying to figure out which code to use based on exactly where a patient lived used to feel like solving a totally frustrating puzzle. Well, the AMA finally listened to us, and they completely overhauled the guidelines. So today we're going to break down exactly how to master these changes, make sure your documentation is absolutely bulletproof, and, most importantly, get your providers reimbursed correctly without triggering a nasty audit.
Okay, let's take a quick look at today's agenda. We'll start off with the home care framework, move right into new patient codes, discuss established patients, and then wrap the whole thing up with those absolutely crucial coding and audit rules.
All right, let's jump right into Section 1, the home care framework.
So according to the updated CPT guidelines, this category is a real game changer because it brilliantly unifies traditional private homes with short-term lodging, assisted living, and group homes into just one comprehensive framework. Historically, you literally had to jump between different confusing code sets depending on whether the patient was in a domiciliary, a rest home, or their own house. Well, not anymore. Whether the provider is seeing the patient in their private suburban home, maybe a hotel room they're just staying in temporarily, an assisted living facility, or a board-and-care group home, you're going to use this single 99341 to 99350 code family. The only exception is a licensed intermediate care facility for individuals with intellectual disabilities. That still uses a different set. But overall, this update makes our lives so much easier.
And when you look closely at how the CPT manual specifically categorizes these as evaluation and management services provided in a home or residence, the beauty really is in the simplicity. The old blurry distinctions have been totally erased. That means your primary focus as a coder is no longer hyperfixating on the facility-specific licensing status, but rather on the actual medical necessity and the clinical complexity of the visit itself.
Moving right along to Section 2, new patient codes, covering 99341 through 99345.
Just as a quick refresher, a new patient is someone who hasn't received any professional services from the physician or another physician of the exact same specialty and subspecialty within the same group practice within the past 3 years. When you're selecting a code for them, you have to map the encounter to either the medical decision-making level or the total time threshold, which starts at 15 minutes. So for a 99341, you need straightforward MDM, or 15 minutes of total time met or exceeded on the date of the encounter. For 99342, that jumps to low MDM, or 30 minutes. 99344 requires moderate MDM, or 60 minutes. And finally, for your most complex new patients, 99345 requires a high level of medical decision-making, or a whopping 75 minutes of total time.
Okay, I really need you to pay attention to this next point. Notice that deliberate gap in the sequence? Make absolutely sure you don't accidentally code a 99343 because it has been officially deleted. We jump straight from 99342 over to 99344. If you have older templates lingering in your EHR, or if you're just typing from memory based on how you coded a couple of years ago, putting a 99343 on a claim today is a guaranteed instant denial. The AMA removed it to streamline the time and MDM gaps, so always double-check your sequences.
All right, shifting gears to Section 3, established patient codes, which are 99347 through 99350. Now let's look at established patients. A straightforward established patient visit, code 99347, requires 15 minutes of total time. Moving up the ladder, 99348 for low MDM hits the 30-minute mark. 99349 for moderate MDM requires 45 minutes, and 99350 for high MDM requires 60 minutes. You really have to keep these two separate tables clear in your mind, or honestly, ideally printed right on your desk. You want to ensure absolute precision, especially when crossing that moderate threshold, because it's 45 minutes for an established patient compared to 60 for a new one.
And finally, Section 4. We are officially entering the danger zones, coding and audit rules.
So here is the absolute bottom line. You must choose either the MDM track or the total time track to select your final level. These are mutually exclusive methods. The recent AMA guideline updates completely tossed out the old method of counting up history and physical exam bullet points. Now, you just evaluate the documentation in front of you. Say the provider spent a massive amount of time counseling the patient or reviewing extensive past records on the day of the encounter. Well, then time might be your best bet. But if it was a really short visit where the provider managed a highly complex, life-threatening exacerbation of a chronic illness, medical decision-making is definitely going to yield the higher, more appropriate code. You use whichever method allows the highest appropriate reimbursement, but again, you only use one.
Let's carefully unpack these documentation rules because they are strict. First up, exact itemized time means exactly that. No more estimating or rounding up. The provider needs to explicitly state something like, "I spent 35 minutes today." Second, a medically appropriate history and exam are still 100% mandatory, just to prove the visit was actually necessary. Third, if you max out the time thresholds for those highest level codes, you've got to append a prolonged services code. But here is where you have to be super vigilant. Use CPT code 99417 for commercial payers, but if you're billing Medicare, you may need to use HCPCS code G0318 for encounters that exceed the maximum time thresholds. And speaking of Medicare, be acutely aware that they have a very strict homebound definition for home health care that differs wildly from the basic CPT location requirements for an outpatient provider home visit. CPT basically just cares where the visit happened, but Medicare requires distinct clinical justification for why the patient is actually considered homebound. Always check your specific payer rules.
Listen, here is a massive compliance trap right out of the manual. You must explicitly exclude any provider travel time from your total billable E&M time calculation. I literally cannot stress this enough. If a physician drives 45 minutes out to get to a rural patient's home, spends 30 minutes treating the patient, and then drives 45 minutes back, the billable time is exactly 30 minutes. Full stop. The AMA guidelines are incredibly strict on this. Travel time simply does not count toward the total time on the date of the encounter for E&M code selection. If an auditor sees travel time baked into a time-based coding claim, I guarantee you they will claw that money back immediately.
So you now have the complete framework to confidently navigate these settings, choose the right codes based on either time or MDM, and completely steer clear of the biggest compliance pitfalls out there. But ask yourself, is your practice's EHR currently set up to properly split time versus MDM, or are outdated templates actively putting your revenue at risk of an audit? Go check your system today and make sure you're protected. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.